Hello friends, this is DrRBKushwaha, professor in the Division of Veterinary Clinical Complex at MBSC and it is called Jammu Araspura. Welcome to my YouTube channel, and if you are new to my channel, so kindly subscribe my channel and hit the bell icon for the notification. So today we have a very interesting case in a 1-year-old culture farm dog. You could see this is a very cute and small breed dogs, but this cute dog had injury 3 days back, and he slipped from the staircase and got injury in the left femur bone. So you could see here, so the animal is not putting weight on this left hind limb. And when we took the radiograph, so we come to know that there is a metaphyseal fracture, distal metaphyseal fracture of this left femur, as well as there is a cranio-dorsal luxation of this head of the femur. So this dog has two problems. One is the distal metaphyseal fracture, and at the same time cranio-dorsal dislocation of this femur. So today we are going to perform the surgery of this dog. So we plan for first we manage this metaphyseal fracture, and then after the fixation of this fracture, so we make the whole femur as a single unit, and then we go for the toggle pinning. So this toggle pinning is a very good technique to perform the open reduction and maintenance of this head of the femur in the cotyloid cavity. So this is our plan of the treatment for this particular dog. We will prepare this side by saving this much area all around this, and the medial side, caudal side, cranial side, and up to this mid trunk. So we shave this hair and then we scrub with the chlorhexidine and the cetrimide solution, and then we anesthetize this animal with the combination of atropine, xylazine, and the ketamine anesthesia, and then we maintain the anesthesia by the diazepam and the ketamine mixture. So now we have placed this animal in the right lateral recumbency with the affected limb uppermost. Now you could see here, because of the cranio-dorsal luxation here, the normal anatomy of the gator to canter has disturbed, and upon radiography here the metaphyseal fracture. So here initially I planned for the dynamic cross pinning, but here first I will make an incision for the metaphyseal fracture, and if I find that okay, it is not possible to perform the intramedullary pinning using 3 mm steel band pin, then only I extend the incision for the arthrotomy and then open the stifle joint and then perform the cross pinning. First I will try to fix this fracture with the intramedullary pinning. If I will not succeed, then definitely I will go for the cross pinning. If you have the fracture as well as the dislocation, so first we prefer to fix the fracture so that we make the femur fracture as a unit, and then we go for the toggle pinning. So for the landmark here, since I have applied this incision adhesive tape here, so this one is the anterior tibial tuberosity, this one here it is the basically a stifle joint, here is the patella, so this one. So I give the incision here, and once I perform this pinning, so I will extend the same line of incision here. Seizure, Nudgen bone. This is the skin incision. Here we make the incision in the tensor fasciata. Here this is basically, it is not exactly over, this is the biceps femoris. So here it is basically tensor fasciata. So this is a very small size breed. This is the culture pom. It is 13-month old, but its body weight is around 3.5. Kindly keep the anesthesia, please. This is the junction of the vastus latalis. This muscle is vastus latalis. This one is the tensor fasciata, which I am holding here right now, and this one so now you could see this is the shaft of the femur here. We simply separate with the this is the very small breed, so when the medullary cavity is very small here, you could see. This one is this one is small. So whatever the instrument we have, that instrument definitely will appear longer for this particular breed. Give me the instrument pin introducer. So this one is the proximal fracture fragment, and distal fracture fragment is very small. Now you could see here it is very close to the condyle. So medullary cavity diameter is very narrow, so the earlier which I made with the 2 mm pin, that was not sufficient, so that's why I am again reaming with the exactly the same pin which I have to insert. Now it has come outside. So in this case there is a cranio-dorsal luxation of the hip joint, that's why we are not doing this normal intramedullary pinning, because sciatic nerve is running just below the greater trochanter, so there may be chance of the damage, so that's just to avoid that one. Let me hold with the reduction force. Reduction force. Selected one. Yes, this one. me see the first. Yes, now it is visible. Now it is slightly visible. Now you could see. So this is the medullary cavity. So slightly advance the pin, this one, so that it come at the proximal fracture fragment. Slightly advance. Yes ma'am, थोड़ा सा advance करिए. बस. Yes. एक मिनट. This. Wait for the. Yes, now advance slowly and slowly. Yes, ma'am. Unidirectionally. Advance in the only one direction. Leave it. So let me see the first we hold, then see the stability. Yes. Could see here, so yes, the reduction appears to be very good. See. One or two round. Wait. Yes, you can go. Yes, advance few. Two rotation. Just wait. So now it has, I think, about near to the articular surface. So this is the proximal fracture fragment, and this one the distal. So I think yes, it has gone very nicely in the distal segment. No movement. Both fracture fragment are moving as a unit. It means okay. So first we just go for the temporary here, and then we perform the next procedure. You just remove here now. So this is the stream-on pin cutter or pin cutter. No, so this is exactly 3 mm intramedullary pin, so we can cut up to the 3 mm. So we have fixed this femur fracture at the distal aspect or metaphyseal region. So here is the pin, and this one is the gator trochanter. So the same incision wheel here, basically we give the incision from the here in a curvilinear fashion. Bit. With the seizure. This is the all fat we have to cut or remove. Now you could see here, so this is the middle gluteal muscles is visible, superficial is very fine here, and this one is the tensor fasciolata. Give the anesthesia. So these are the fat. We can remove also. Mop it, Dr. please. So now you could see here from here onwards. So this one is the side is the fat. Give the hormone detector. So now you could see this muscle, which is the middle gluteus. So we reflect this middle gluteus.
दो प्रॉम्प्ट्स वाला भी है ना
लीजिए
दो जॉस वाला
So this one right here, this one is the deep gluteal and this one is the middle gluteus, yes, this whole. So this one is deep gluteal muscles. So this is the leading edge of this biceps femoris. This one, and you see here, so this one is the gluteal. So now you could easily see the insertion point of the difference. So this one is the deep gluteal, this is the vastus latalis. So we have to cut this one deep gluteal muscles partially or sometime completely. Leave it, ma'am. So this is the tenectomy. Even if you cut completely, no harm. So now you could see. So normally after cutting the deep gluteal muscles, we could see the joint capsule here, the fibrous joint capsule. But in this case, because since it is luxated, so here if you see, so joint capsule already torn. So this is the reason why you could see here the directly the head of the femur. So now the next step, we cut this muscles also here to see the neck, and to because of the cranio-dorsal luxation, the stapler cavity is basically obscured by this particular part. So let me explore this one also. Blade, give me the blade. Yes, this one. So here now we follow the neck here. So this is the, so we cut below the hair. In order to see the neck of this femur bone, now you could see this is the neck here, this white structure, it is neck, this is the head. So with the help of this hormone detector, we try to lift this one, and now try to see the stapler cavity here. So now you could see this is the torn hair. From here this is the fovea capitis, and here the round ligament is attached. So but first we fix the toggle pin in the stapler cavity. For that we rotate the limb externally and then pull please Dr. Tinku, pull this limb distally here. Also take care of this femur fracture which we repaired. This one is stapler cavity here. Yeah, this one. So this is a very small stapler cavity. Dr. Ashish, focus this one, this area. Now you could see here this very small. Yeah, now you could see. Now you could see this is a very small stapler cavity here. This one. So this is the imported toggle pin, and so this is basically a button for the fixation at the greater toe canter. So this material is sent by Dr. Imran Ali, who is posted at the Dehradun, Uttarakhand. So I am really thankful to Dr. Imran Ali. So I hope that I am able to perform this toggle pinning. So this will go from here. We will insert this one. So we will basically hold like this. So through the hole in this cotyloid cavity or stapler cavity, then we push, and then at the medial surface what happened, it will drop. So when we will pull, so it will anchor at the medial surface. So while drilling this stapler cavity, we take care that we should not pierce very deeply, because the colon is located just at the medial side. So this is the cotyloid cavity. So here we make the hole in the stapler cavity slowly and slowly. We should not. So it has gone. So care should be taken while drilling in the stapler cavity, because colon is medial to the medial surface of this cotyloid cavity. So now next step is we insert this imported toggle pin with the thread. So now you could see here, so we have fixed this toward the medial side. So now the next step, we drill from the fovea capitis into the neck and up to the hair. Pin which is in the trochanteric fossa that is causing problem in the drilling, so that's why we have drilled here in from the fovea capitis to the slightly here neck, and it is not exactly coming exactly at the greater trochanter, it is slightly here in the side. So since this is a very small braid, so I hope that even this much is sufficient. Engage the both wire here. Hold it. Now we compress here. So it is coming here. So simply with the help of this one we pull it. This one. So now we rotate extensively here and pull it. So now it has seated in the yes. So this is the head of the femur. Now you could appreciate that this has gone inside the here. I could feel the this. Now you could see here, this is the joint capsule here, this fibrous joint capsule, and it has gone. So further we rotate here, and then so I'll maybe just put here. So now next step is to engage the button. So here we should separate, it should exactly here to slightly separate the muscles to expose the bone. Put like this ma'am, okay. So before tying we should check the rotation. We should not tie too tightly, otherwise it will torn when the animal make a ambulation. So yes, I think this much is sufficient. So at least 5 or 6 throw we should put. So put the number saline. So if you see here, so the button is not at the greater trochanter, it is over the neck, because the hole, the drill we have made, that is not in the neck and the hair. So this is the region. So this is not a perfectly repaired, this is perfectly done toggle pinning. This is also a little bit luxation. So we will try to give the thumb forceps. So whatever structure we will find here, we will suture first. For the further support, bone anchors and some fast tag is, but here since we don't have, so
कट करना है इतना।
cut कर दो. So here you could see nothing is, the bone capsule is not visible. So whatever the structure, so this one is the fibrous capsule torn. They also torn too much. Here we repair this. So here it is our facial attach. Here we will close the. And this, with the same incision we repair this one also.
दो एंड थे ना, एक और भी है ना।
So now we have repaired this incision line over the fracture, and for this repair of this cranio-dorsal luxation of this hip. So this repair is not up to the mark because of this pin which is present in the medullary cavity, which prevent the drilling from the head to the neck and ultimately at the ventral trochanter. So we make the tunnel only up to the neck, and we fix this button at the neck. So this is not 100% reduced, but since this is the only 3.5 kg dog, this is the small breed dogs, toy breed dogs. So we hope that this will, you can say, even immobilization we will give for the 14 days. So definitely there will be fibrous tissue formation, and this one is sufficient also to prevent. So next step is just to repair the skin, which is nothing special. So thank you very much for watching this video, and special thanks to Dr. Imran Ali who provided this toggle pin. So this is the condition of the same dog after 1 month of operation. So now you could see the animal how he is putting the weight on the affected limb, and animal is able to walk properly.